Hello, everybody. Thank you for joining us. Today, Cancer Care Virtual Seminar's topic is Cancer and Sexual Health 101. My name is Carmen Boone. I'm an outreach coordinator for the Samaritan Cancer Resource Center, and I'll be your host and moderator today. This event is brought to you by the Samaritan Cancer Resource Center, and we partner with anyone touched by cancer to provide the support they need to live with a strength, determination, and hope into the future. Joining us today is Jessica Bell, physician assistant and surgeon from Samaritan Gynecology and Surgical Associates. I'm going to pass the presentation over to Jessica Bell right now.
All right. Hello, everybody. I'm so happy to be here. Can you hear me and see my screen okay?
Yes.
Okay, wonderful. All righty. Well, I work for Samaritan Health Services in their urogynecology and surgery departments. We are on 9th and Walnut. We are not with the OB group. I work here in the clinic. I also work in the operating room. So in the clinic, I see patients and treat them for their urogynecology concerns. I also see our pre and post-op patients as well. But in addition to that, I have kind of a special niche of my practice in regards to female sexual medicine. And this was really born out of patient needs. So when I delved into this, like I say, it wasn't anything that I necessarily planned to do, but as I started my practice here, I soon found out that ladies needed me to do the education in order to help them the way they deserve to be helped. And today I'm starting off with kind of a basis of information on female sexual health. And then we will have a part 2 of this presentation as well. So through my clinical practice, I've definitely found out that, we don't often know about our anatomy. And in order to kind of discuss those changes that happen with cancer treatments, we definitely need to have some place to start from. And that's the purpose of this presentation today, is kind of as a primer for what's to come. So if you don't get answers to your questions today, or it's not in the presentation, it might be in one to follow. So why are we doing this? Sexual health definitely evolves throughout the lifespan for everyone and changes significantly with cancer. So chemotherapy, radiation, medications, and surgeries can all create a situation where you're being pushed and pulled definitely between being thankful for those treatments and then finding ways to navigate the new that's been created. So this can be daunting and frustrating, especially when there's misinformation at play. And we have come to honor that sexual health is a quality of life measure, and we'll go over that in a moment. The studies definitely showed that if this goes unaddressed, it can affect us in a lot of different ways in our emotional well-being, mental health. That can affect current and future relationships, but can be navigated, especially with the help of professionals and a multidisciplinary team. And that's what I'm hoping to do here at Samaritan, I would say, is provide that support to patients if and when they need it. And I say if and when because I also want to honor, everyone's unique experience, right? Some people are definitely just trying to focus on the diagnosis itself, the treatments and living, and sexual health isn't at the top of their priority list. But what we don't want to do is not advise or provide anticipatory guidance to somebody on that assumption. We wouldn't do that in regards to any other side effects or health changes that we would expect with treatments. And that should be the same case with sexual health. So it's okay for sexual health to not be a priority for somebody now or ever, right? This is definitely not intended to push this information on anybody, but is provided as a resource. And again, and honoring that these treatments can impact our sexual health. So starting from the beginning, like I say, because a lot of us never receive this foundation information, today I plan on talking about basically, in my opinion, all the things that we wish we had learned, or all the things that my patients say that they wish they had learned sooner. It's definitely developed out of my clinical experience and then formal education. And as I say, this was inspired by my patients. As they started to come to me with these concerns, I obtained the knowledge for them. And again, this is for you in the way that I want to present the information that you need. So as we go through this, if anything is lacking, I definitely want that feedback. And then, like I say, there might be more to come. So sexual health is health. The World Health Organization says this, that sexual health is fundamental to the overall health and well-being of individuals, couples, and families, and to the social and economic development of communities. Let's see here. And countries. Sexual health, when viewed affirmatively, requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. And that's the World Health Organization's position on this. So I also have here some different things, intimacy and sex are definitely different, and that's something that we'll probably talk about more in depth down the line. So language, starting off on the right foot and just getting some history, recognizing the importance of language and even of bias. So language is important. I will be using some heteronormative language in this talk, but I'm definitely sensitive to and honor people who are women but do not have female organs. This talk may come off as being more focused on heterosexual relationships. And if there's any areas that I don't specifically address important to you, please let me know. So some history of language, I find this to be interesting. Hysterectomy is the only surgery not identified by the organ being removed. It comes from the Greek root hysteria. They thought that the uterus wandered around the body and needed to be removed. Literally every surgery that we perform is identified by the organs being removed. Pudendum, the pudendal nerve. The pudendum is the shame package. Shame, shame, shame. Vagina means sheath or scabbard, sword holder. So I spell this out because, as you can see, there is kind of some shame even built into the language that we use in regards to female organs. And then as we go on, you'll notice that I will use the term sexual debut instead of virginity. And then just to acknowledge, we all have implicit bias that can come through. And as a female sexual medicine provider, I definitely work to unlearn and undo this bias in myself, but it still happens sometimes. So anatomy, this is really important. Being a clinician, I find all the time to, no fault of our own, we don't know the details of our anatomy. And again, that can be difficult when understanding what's going on with our body, how things are changing. And then definitely when there's a treatment recommendation made. For example, I give ladies a lot of different creams and ointments sometimes. And I can't, necessarily just tell them to place it at their urethra because admittedly, we don't always know where that's at. So taking a moment to kind of see this side view, I think is really informative. This is the Vulva Gallery. They are an amazing artist. You can see kind of how everything lays together in this side view. And then the vulva, I'm going to take a moment really truly to talk about the detailed anatomy of the vulva here, because again, these things all change and they change significantly sometimes with cancer treatments. And we'll talk about that down the line, some of those different tissue changes that you might experience and where they're occurring. So the external clitoris is up there at the top. The hood covers it and protects it. We should be teaching young girls, and even in clinical exams as clinicians, we should be pulling back the clitoral hood to expose the glands of the clitoris. The clitoral hood is kind of similar to male foreskin in that it can get stuck over the glands of the clitoris. Debris can get stuck under there, which can actually form into little keratin pearls and stones that sometimes can be asymptomatic, but in other cases can be irritating and uncomfortable. And of course, if the glands of the clitoris is covered completely by the hood, that might cause either a decrease in sensation or for some, an increase in unwanted sensation at that area if you have that little debris bothering all of those nerves. And then there's the frenulum between the clitoris and the urethra. The urethra is here. The Skene's glands are next to it. We'll talk about those later. Then there's the entrance of the vagina and the vestibule, which is a very important part of the vulva because this is both estrogen and androgen rich and can be very sensitive and painful, to be honest. So most of my ladies are getting a detailed picture when they leave my clinic because sometimes, first of all, they haven't known these details before. And then secondly, it really helps if I am prescribing creams or ointments to know where to put them. Okay, labia. They are all normal and sensitive. So I say this out loud because there's definitely an increase in requests for labiaplasties. And I would say in part because, again, you know, the stories that we're told when you only have one vulva of your own and you don't do all the exams somebody like me does, it can be very common, to maybe think that yours is different than others and that's wrong, but it's definitely not. So just like my ear is different than your ear, it's the same with the labia and with the vulva as well. For that matter, even the labia themselves are not twins, they are sisters, right? So we are all uniquely different. There is nerves in the labia and anatomy to consider. The labia can change over time, right? So when we're young girls or even adolescents, our labia are different than they are when we're older. So when we're younger, they're quite small as infants, and then kind of as estrogen happens, they start to get longer. Actually, when girls are in their adolescence, teenagers, maybe sometimes when they are most concerned about their labia, they might be a bit longer at that point than they will, say, when they're 18, 20, 30 years old. They diminish a little bit. And then for sure, as we lose estrogen, whether that's naturally through hormonal changes or for some people with medications, the labia can become diminished. There's also some vulvar skin conditions that can cause sometimes complete what we call absorption of the labia. So this slide is really provided to just let you know that we are all uniquely different, and that's something that my ladies don't know until I reiterate that for them. I do recommend that all women either complete their own vulvar exam or ask your gynecologist to do this with you for a better understanding of your anatomy. Of course, if you're comfortable with it, right? There's, again, a lot of shame around this. So the idea that could be traumatic for some people, but it's definitely, powerful. It helps give you an understanding of your own anatomy and then definitely of evaluation and treatment recommendations. I have a mirror at the bottom of my drawer in my clinic, so I'm always offering that to ladies if they would like to look at the vulva with me, especially if I have some specific findings to point out to them. And that's, very normal. And it's also great then when I initiate that treatment and they come back and they can see those changes visually themselves. And again, since we're starting from a foundation, I wanted to take a moment for some myth busting. So sometimes we continue to tell a story until it becomes truth, even though it's not. So the hymen is not intact. There is no exam that can determine if a person has had their sexual debut. If the hymen was completely intact, we would not be able to expel blood through the vaginal canal. So just a quick moment to debunk that myth. The clitoris is the female sexual organ, just like the penis is the male sexual organ. And I love this slide here because it shows that evolution. And again, as we start to honor the wide variety of people in the world and anatomy as well, we start to find that, it's not so binary, black and white. And I think this picture describes that well. The clitoris is an internal and an external structure. I have these pictures here to kind of show you how it lies underneath the vulva. And a lot of people do not know this. So no surprise if this is new information to you. That is definitely okay. And here's one of the reasons, right, why we don't know so much about the clitoris. Who owns the clitoris, and do we understand? Someone I consider a mentor of mine, Dr. Rachel Rubin, she is a urologist, shared this slide at one of my conference presentations. And this is really how it is. You know, OBGYNs don't always claim it, urologists don't, primary care. I work in urogynecology. It seems very appropriate for us, and admittedly, it seems quite appropriate for everybody else as well. So Helen O'Connor first mapped the clitoris in 1998. Jessica Pinn detailed the clitoral anatomy in 2019. Her study was actually born out of her own trauma and loss of sensation at the clitoris from a labiaplasty. So she is a patient advocate who also has access to research, and she's definitely making some waves in regards to this, getting some textbooks changed. So detailed clitoral anatomy just didn't exist until recently, right? So that's one of the reasons why we don't know it. And it's been omitted from textbooks in the past, and definitely still is. Again, you know, we don't have a great understanding. However, it's curious because it is the female sexual organ, just like the penis is the male sexual organ, and we definitely know a lot about the penis. So why don't we know more about the clitoris? The study that quoted the number of nerves in the clitoris is a bovine study and is yet to be adequately measured in humans. That's just a statement. A lot of the times you'll hear there's 8,000 to 10,000 nerves in the clitoral glands. Again, that is not done in human studies, so we don't really know the answer to that question yet. Anatomy of arousal. This is vitally important, okay? The clitoris has an aroused and a flaccid state. It fills with blood and engorges. Some people describe this as an erect state, but there is no actual erectile tissue. The filling can create a sensation of warmth and promote the transudit that is vaginal lubrication. Genital response or arousal does not always equal desire for a sexual experience. So this is why arousal and lubrication can definitely occur in an unwanted, undesired experience, and why sometimes it does not occur when we desire that experience very much and really wish that we had the arousal and lubrication or the lubrication to go with that, right? So use the lube at any age all the time. I am on a big no lube shame kick. It increases pleasure, decreases friction that causes micro tears and possibly infections. Silicone-based lubricants are often preferred over water-based, and I wrote a few down here. Uberlube and Swiss Navy are good silicone options and can be found on Amazon for that matter. So now that we know about the anatomy of the clitoris and how it works, that it is that internal and a little bit of an external organ, there's a better understanding of this as well. So about 3/4 of women will not climax with penis and vagina intercourse alone. And this is quite surprising to a lot of the people I see too, because we're definitely told a story that that's the way it's supposed to happen for us. And then sometimes we feel like there's something wrong if we can't do that. But again, now that we have a better understanding of the anatomy, it shouldn't be too surprising that this is the case. And some people even say, you know, the better question is not why does it happen, it's why does it ever happen with intercourse alone. So clitoral or coital alignment technique is a position during intercourse that can be helpful when attempting climax with penetration alone. Adding in clitoral stimulation with a vibrator or hand can be necessary, and this is okay. Again, it is anatomy and physiology. Vibrators are teammates, not competitors. Dr. David Frederick did some studies on sexual orientation differences and orgasm frequency and found the orgasm gap exists for heterosexual women primarily. And so he asked, you know, okay, what occurred? So his study showed women are more likely to orgasm if the last sexual encounter included deep kissing, manual genital stimulation, and or oral sex in addition to vaginal intercourse. So there is a bit of a recipe for how to make things more pleasurable. And in general, it's important to know how our bodies work so we can communicate that with a partner, and to know that every body is unique and responds differently. Again, you know, we are not the same as another person. The fact is women and men don't know this anatomy and physiology, and teaching it is a big part of my practice when we should have known this long ago. And again, you know, avoided some of the distress we have over what we think is dysfunction when it's likely just quite normal. So what is an orgasm even? I definitely have patients too who say, they don't know if they've ever experienced an orgasm. So I gave the scientific definition up here for you, but many people, and again, we've studied this as kind of stigma and shame decreases. We are able to study these things now. And what we find is sometimes what people report as being an orgasm might not fit the clinical definition, but it's definitely pleasure, so who cares, right? There are different types, clitoral versus cervical versus vaginal versus blended. And ladies often ask about, is ejaculation or squirting a real scenario? Or I have one person who wondered, can orgasm happen if that doesn't occur? And yes, of course it does. Ejaculation and squirting doesn't happen with every person. It doesn't happen with every orgasm. But there is a periurethral sponge under the urethra. Each person's anatomy is so uniquely different. Fluid comes from the Skene's glands, which are just right next to the urethra. This fluid is not urine in and of itself, but sometimes there is urine in it, just like there's urine in male ejaculate. So take-home message there is just that it is a real occurrence. However, like all things, are exaggerated in entertainment purposes for sure. Orgasms can change over the lifetime, right? So this is also normal and common. The same stimulation used in the past to create orgasm may change in the future for many reasons. So have an understanding of that, be curious with it, and also be patient with it, as admittedly that can be frustrating. Again, less frustrating if you know that that's something to expect. And then this is a big one, right? I mean, I'm sitting here talking a lot about orgasms, and that's because they're healthy. So they release endorphins and increase cortisol, which can relieve stress. So just like recommending exercise for cardiovascular health, providers should consider that as well. Orgasms could be recommended to treat depression, sleeping disorders, and to maintain the pelvic floor, help sexual function, and treat vulvodynia. So like I say, research is finally being done, but it is limited due to that stigma, even though we do honor this as health. So pleasure, what is pleasure? It is your brain's reward. However, this is that is monitored through sensation, right? So you experience a sensation which then travels into your brain, and your brain decides how to interpret that. That is very dependent on the scenario. And a moment too for this, right? So pleasure and sex are not the same. We can talk about pleasure without sex. My 3-year-old the other day said, well, he's 5 now, but it was a 3-year-old jet quote, said, this is so satisfying. And that was just a young person describing, this is pleasurable, this feels good, right? So, and then again, that comes from the brain, that context, that sensation. Is this sensation pleasurable or is it painful? All of those different things. So if we honor the mental component to sex and pleasure, we can work with that. So paying attention to general response, arousal, and pleasure can connect to desire and increase wanting. Sometimes using autoerotica and fantasy can be helpful to increase pleasure as well. And also, it's not fixed, right? It can fluctuate, it can be changed. But here's some of the limitations. There's guilt associated with pleasure. There's a story that we've been told that we have to wait for a certain moment. But the messages are also mixed. Have pleasure, but not too much, and only if this. And then learning to unlearn the structures that have prevented this access is difficult, or sometimes feels impossible. It's not. And so how can we address this? Mindfulness is definitely a great way to do this. Dr. Lori Barato wrote the book Better Sex Through Mindfulness, How Women Can Cultivate Desire, and these are things we'll talk about in other presentations. And then Dr. Jessica Gorman is actually an OSU professor here locally who does research on mindfulness. Desire, spontaneous versus receptive desire. This is also very important in a clinical pearl of mine. So spontaneous desire shows up instantly or without stimulation, just kind of out of the blue. That's much more common for men, who often respond more to genital sensation or sexual visual stimulus. Not as common for women, and so again, normal. But the story we're told is, you aren't initiating, you don't have, the spontaneous desire. And so we're told that that's an issue with us, but really it's just actually common. Responsive desire occurs in response to stimulation or something sex related. So that's when you've planned for intimacy and you're with your partner and things evolve, and that is responsive desire. Then there's contextual desire, and how the environment impacts our ability to feel that. So sometimes it can be difficult to even create the responsive desire if the context is lacking. So stress, distraction, all of that can be put some brakes on our desire. If you're at the end of a long day of work and the dishes aren't done, it's not a good context for desire. And desire discrepancies are very common. Emily Nagoski wrote the book Come As You Are. I recommend that to everyone I know. She describes very beautifully accelerator and brakes that impact desire. Communication and consent. This is very important. Consent, boundaries, and communicating about this is vital, no matter how new or established the relationship is. What we are okay with one day, 1 week, or year or moment can change, and again, that is okay. This is important, especially in my people that are in all people, but in long-term relationships, we can have this assumption of, we're not allowed to change. Or it can be confusing if we have new boundaries, but that's okay, and we need to communicate that. Hormones, this is a big one. This could be a whole talk in and of itself, but I just wanted to give some credit to hormones. They definitely affect us, but how and why? There is a study called 28andMe where women are being scanned daily with MRI to see how the brain changes with hormonal fluctuations. Excited for this one. Estrogen in general, when it increases around ovulation, we'll often feel kind of an increase in vivacity. And then we have some studies that show that there's an increase in the ability to differentiate between senses. It can enhance learning. It can also act as a natural painkiller. It declines and is inhibited for many reasons. So oral contraceptive pills have estrogen in it that's not the same. That inhibits ovulation and can have a muting effect on some people's behavior. The side effects from that are real. Sometimes we don't know these side effects, though, because they're normalized, right? So this is kind of talking about two things at once, but for example, for some people, oral contraceptive pills can cause a change in libido, but if we're told as women that we aren't expected to have a high libido, we might really accept that side effect as being normal and not think anything of it. Testosterone declines in women just like it does in men and can also have an impact on libido, but it's not responsible for it. I do supplement testosterone in some people. It doesn't necessarily just give them libido. So just taking a moment for how they make us feel. Each person is different, and it's difficult to make broad generalizations on how hormones do or do not affect us because the individual experience is immense. So what I know as a clinician and a person is that, these fluctuations are no joke, and the impact for some people is definitely intense, right? So, and that can also be really kind of confusing for women because we can have a very difficult experience with our hormones and talk to a friend or family about that, and they don't have the same experience. And then again, we think something might be wrong with us. Consent and tea. So I also do a Sex Ed 101 talk for high school students, or I did once. I hope to do some more. And I use this visualization. So this is a literal and a visual explanation for consent. So I'll let you kind of review that on your own and take a moment for that as you will. Our body's boundaries and sexuality can change over the lifetime, and that is okay, but let's communicate about it. So communication is important, although admittedly difficult, right? So needs communication. What is your frequency of intimacy? What is your need there? Do you have a certain type of intimacy that you need? And is that at a certain frequency? And then, tapping into your general needs. Again, this isn't all necessarily about sex or intimacy or general health, making sure that you're taking care of yourself in other ways. Desires communication. So want what you want and don't yuck anyone's yum. So we use that term, we don't yuck anyone's yum in sex medicine spaces. That is, yeah, not judging people for their desires or for the things that they're curious about or want to try. You don't need to yuck their yum, but you can, of course, hold on to your boundaries, obviously, for what you're comfortable with and what you're not. No communication. So receiving a no as graciously as you would a yes, and taking a moment to communicate. So yeah, oftentimes we're not in the mood, right? And that's okay. We don't have to be. But it can be nice to describe that to our partner so it doesn't feel as much like rejection. So if a person initiates and you say no, you know, it's okay if you just want to watch the show or read the book or take a walk or do nothing, right? But maybe saying something like that, checking in with them, telling them that you care about them or that you love them and that you want to experience this with them, but not right now. Body communication, very important. So if you have aches or pains or limitations in your body, if you just know that things don't work for you, if you have a history of trauma, if you have things like that, it's good to talk about that definitely ahead of time. And then boundaries, communication. Also, again, what are some of the things that are flexible? Flexibles and hard no's, right? So what are your boundaries? And oftentimes you need to determine that for yourself. Non-goal oriented intimacy, sensate focus as a way to rediscover this, for that matter. So this is a way to figure out what feels good. Take a step back. So there's a giver and a receiver. The receiver pays attention, noticing the sensations, warmth, soft, hard, firm, and removing the expectation that sex is going to be there allows that person to truly experience the sensation and notice it without the distraction of anticipating what might come next. So here's some clinical pearls I'm going to leave you with as we're kind of wrapping up the presentation. As you can tell, I have a lot in my mind and a lot to share with you. But to start, your pleasure matters and it is accessible at any time. You don't have to wait to lose weight for a partner, a certain moment, or until fill in the blank, right? I mean, we've all kind of been told the story, I have to do this before I can access pleasure. But that's not true. This is accessible to all people. And then understand your anatomy, female sexual function, and your own body. This is powerful and allows you to communicate your understanding with a partner if you choose to share it with a partner. Allow yourself to evolve over time. So sexuality evolves and our bodies change. It is a journey. Thank goodness we are not the same people that we were 20 years ago. What you feel as dysfunction is likely very normal and common. Let's talk about it together and unlearn. Now, that's not to say, there's nothing, nothing wrong with you, rah, rah, rah. What this is to say is like, let's clarify, what is the reality? What is the normal experience? And indeed, is what you believe to be dysfunction normal? Less goal-oriented and more pleasure-focused intimacy. So sensate focus is a tool to practice non-goal-oriented intimacy. It results in less pressure for the experience and more pleasure and sometimes more orgasms. Plan for sex. Receptive desire is more common than spontaneous desire. The story we are told about spontaneous desire is false and based off male sexual desire. This is confusing. And this will be for another one too, but be careful not to create that planned intimacy into a duty sex scenario that can become resentful. Being intimate when energy is high is a better experience. So we often wait until the end of the day when we are exhausted. This is not the time for spontaneous desire or even receptive desire often. And again, that's normal. Use lube. It decreases discomfort and increases pleasure. No lube shame. Vaginal lubrication is dependent on more than desire for the experience. Hydration, medications that dry you out, allergies, hormones can all play a role. And then again, about 3/4 of women do not orgasm with penetration alone. Clitoral stimulation is required. This is not dysfunction. This is normal. It's about anatomy and physiology. The orgasm gap exists, but only in heterosexual couples, and we can learn from this. Mindfulness, exercise, and a sexual health practice is helpful. So what's next? So Cancer and Sexual Health 101 Part 2 might be what you thought you were getting today, but now that we have this foundation of understanding of our anatomy, sexual health, and how our bodies work, we can build on this and learn how our bodies change. So specifically how they change with cancer. We'll cover typical tissue changes to vulvovaginal tissues that occur with treatments. We'll touch on dilator use to help with vaginal strictures and prevention. We'll talk about vulvovaginal moisturizers and other over-the-counter options, and we'll also discuss vaginal estrogen and mutual decision-making in some patients, DHEA, pelvic floor PT, and the lesser-known laser treatments. In the future, I plan on also doing a presentation just about sex. How do you find it? How do you define it? What is it? How can we expand our sexual repertoire? Libido, its complexities and how it varies throughout the population and an individual throughout their lifetime, how it's affected. Sex hurts, let's talk tissues, an in-depth discussion regarding this. Mindful After Cancer, I'm hoping to invite Jessica Gorman to talk about her research in mindfulness and Lori Brado's research, how this might be implemented at home and possible future offerings to look out for. Pelvic floor PT and movement with cancer, hoping to have some speakers, our pelvic floor physical therapists talk about that. Dilators and vibrators. The As You Like It Pleasure Shop in Eugene and Ashland is a non-toxic and gender-inclusive store. I hope to do a little seminar on some of those different toys, how to use them, again, what that sexual repertoire looks like. And then at the end, putting it all together, now that we know about our anatomy, changes with cancer, treatment options, how to advocate for yourself, experience this journey, and show up for the conversations. So thank you so much for having me today. Yeah, happy to be here and look forward to more in the future.
Thank you so much, Jessica. It's been very instructive and very interesting. Thank you so much for sharing your knowledge with us. So now I also want to thank the guests, and we'll give our attendees a few moments to write any questions and comments in the questions menu. So please go ahead and write down your questions, type them down for us. And while you are typing your questions, we'll go over contact information and upcoming events. So if you would like to obtain more information or resources about cancer, feel free to contact the Cancer Resource Center by phone, email, or visit our website or social media accounts. If you are interested in upcoming events, contact us to subscribe to our Cancer Resource newsletter. We have a couple of events coming up. On June 29th, Exercising as a Cancer Survivor, and that would be our last talk for our celebration of Cancer Survivors Month. Then in July, we start with Orthopedic Oncology 101. And if you are interested in joining any of our upcoming cancer care virtual seminars, email us or call us and we'll be happy to register you. Now, let's go over your questions. So we have one. A good lube that has no estrogen or petroleum. A recommendation. They're asking for a recommendation of a good lube that has no estrogen or petroleum.
Yes, so Uber Lube, really truly, is a silicone-based lube. It is kind of a life-changing lube. I describe to my patients. I have samples in my clinic that I give to people. You can get it off of Amazon. It's the thing with that is a little goes a long way. So really, truly, don't use too much. Otherwise, there's not enough friction. So Uber Lube is all natural. Amazon has the best price. And then Swiss Navy is another silicone-based lube. It's a good one. And then Slippery Stuff, write that one down too. Slippery Stuff is a water-based lubricant, but it's like this miraculous water-based lubricant. It happens to have been created in Washington State for that matter, but those are all really good ones. And eventually I'm going to put together some sort of a resource on different lubricants, because they are not all created equal. As we research lubricants more, we definitely find that some are more irritating than others, and it can actually cause a drying effect afterwards because they pull some of that moisture out of you without intending to. So I know that Uberlube, Slippery Stuff, and Swiss Navy all have good osmolality. They will not do that.
Thank you so much. They are asking us if these slides will be available to reread. And yes, Jessica Bell will share her slides with us, and we'll send them to you, to all the audience, via email. So please wait an hour or 2 hours after the webinar today. We'll be sharing the slides with you. Also, when it's part 2, they're very interested. Part 2 is going to be on July 21st. Write it down on your calendars.
Yes, I'm really excited for part 2 for you guys too. Like I say, this is a good foundation, but I know that part 2 is going to be where we really kind of describe, again, clinically, those changes that happen with cancer treatments.
Yes, it's going to be great. And remember, this presentation is being recorded, and we're going to post it on our Samaritan YouTube channel, so you can watch it again and share it with anyone that you think would be interested. We have another question. Is almost naked a good lube?
Yeah, yep, that's a good one. And good Clean Love in Eugene, they have a good lubricant as well. And I think that's the one, the Good Clean Love Almost Naked one. That might be what they're referring to.
All right. Then they are asking for a moisturizer that does not have estrogen.
Yes. Yeah, I have a few that I can tell you right now. So V Magic is one that's non-estrogen. It has kind of like some beeswax in it, and it's lovely. Hyaluronic acid suppositories, or there's Halogen is a hyaluronic acid vulvar moisturizer. I know using the word acid sounds weird when we're talking about this, but there's hyaluronic acid face stuff. It's a similar preparation for the vulva. There's another one called Kindra, Kindra, and it's a vulvar moisturizer that comes in, like, they have a little egg kind of device that you put it on, this little egg kind of device, and then it just kind of sits there at the entrance of the vagina and the vestibule. So that's kind of a nice way to apply it. Really, truly, oftentimes, the gentle moisturizers that you might use on your face, Cetaphil, Eucerin can be used on the vulva. Coconut oil can be used on the vulva as well. And however, if you're a person that gets yeast infections a lot, then probably coconut oil is not a great option, but that's kind of nice to have some. And there's another one from the Rosebud Company. It's a vulvar moisturizer called Honor. It is lovely. So there's a lot of different preparations out there. I think that sometimes it's a matter of, cost of the medication. Yeah, and like what that looks like for you, right? I mean, some ladies are fine spending, a ton of money on a face moisturizer. It might be fine spending money on a vulvar moisturizer too. It doesn't necessarily mean that more expensive product is going to, give a better result or be that much better. But if you like it, you like it. And I do plan on definitely, again, in the part 2, detailing those vaginal moisturizers, the over-the-counter vaginal moisturizer preparations. That's going to be a big part of that part 2. So you guys can just have that written down and have kind of a list to refer to.
Perfect. Thank you so much. And that was our last question.
Okay.
Thank you so much. Let me see. Let me verify. Yes. There. For our audience, if you have any questions that you would prefer to be answered privately, please email us at cancerresourcecenter@samhealth.org, and we will facilitate your contact with Jessica. All right? So thanks everybody for your questions. Now, once we finish the webinar, survey will open up. So please fill it in, and it will help us to plan future events. Thanks to our speaker for sharing your time and knowledge with us. It's been a wonderful experience today. And finally, thanks to all of our participants today. And finally, you may now disconnect and have a great day. Goodbye, everybody.
Bye.